Let's get started. We're going to talk a little bit about ultrasound for peritonsillar abscesses. Okay? So peritonsillar abscesses are classically taught as being an anatomic diagnosis. You look in the throat, you see, this large swelling on a tonsil, uvular deviation to the other side. You've got a classic history. And then what traditionally people would do prior to the advent of more advanced imaging modality is they would literally just take a needle and they'd aspirate at the superior, the middle, and the inferior pole. If they got pus back, it was a peritonsillar abscess. If they didn't get pus back, then they said, hey, it's a tonsillar cellulitis, and we'll just give them some antibiotics and send them home. And it was a pretty quick diagnosis at that point. So that has been the paradigm that we've dealt with peritonsillar abscess treatment for a long time. Except for apparently my clicker is not working right. There we go. But most of the time now we end up getting a CT scan, okay? And some of that is our desire to avoid giving patients an unnecessary, kind of procedure, right? We perceive that sticking them in the tonsil with a needle or stabbing them with a blade is a little bit higher risk. We don't really want to do that, if we don't have to. And so we kind of want to nail the diagnosis before we initiate kind of the therapy. And I personally think that we over-CT folks for this. And I know some of you guys may be like, Arthur, you're like the king of testing. But this is true. I think that this is something that doesn't need a CT. So the average CT of the soft tissue neck costs in 2021 Medicare dollars around $205, $204.12. So not inexpensive. That's what Medicare reimburses to the hospital for a CT scan. And it turns out that it's not benign. So these CTs actually do carry an increased risk of radiation. In particular, the risk of thyroid cancer for somebody getting a CT of the neck is 1.78 times higher than the general population, and it's significantly higher. And it's something we don't think about. So there's a monetary cost, but there's also a risk to this patient. You can think about if it's a 70-year-old person, perhaps they're not going to survive long enough to bear the consequences of that radiation. But if it's a 20-year-old person, they might, and it's not insignificant. On top of that, there's been a lot of studies showing that anytime you get advanced diagnostic imaging, there's going to be a delay in disposition. And then in particular, in folks who had CTs for peritonsillar abscesses, there's been a study that looked at this and showed essentially you're going to have a delay in time to consult, a delay in time to your bedside drainage, and a delay in time to admission. So CTs mean the patient stays here longer. I think we can all agree that that's something we don't like, right? We want our patients to be cared for. We want them to be cared for quickly. And CTs sometimes slow that down. And that's not unique to our system. That's seen in a lot of other places. So what about ultrasound, right? Ultrasound is something that we can do at the bedside. Can potentially give us that same kind of anatomic information up front, but you and I control it. It's a little bit faster maybe. It's a little cheaper. So if you're billing, depending on what CPT code you want to bill, it's close to $100 cheaper, 90-ish bucks cheaper. It's $119.33 for an ultrasound soft tissue neck, and that includes both the hospital fee and the professional fee, and that's in 2021 Medicare dollars. But what about the test characteristics a little bit? So there's been a couple of studies on this. There's not a ton of data out there, so this is actually a ripe area for somebody to investigate more, but there are some studies looking at this. They basically said, hey, intraoral ultrasound is somewhere in the 95 to 100% sensitive. It's somewhere in the 70 to 78% specific. And so it's a fairly good test. And there's been a couple of studies saying, hey, what about that old traditional way of looking at this where, hey, it looks like a peritonsillar abscess, I'm just going to stick them, versus, hey, I'm going to use ultrasound. And what they found was your aspiration success with ultrasound was 100% in one study. And in Landmark, it was only 64%. ENT consult rate was lower with ultrasound than it was with Landmark-based. Your CT utilization was less with ultrasound than with Landmark-based. There was another study later on that looked kind of, hey, after we brought this up earlier on in the advent of ultrasound, what was the effect? Said, hey, successful aspiration still pretty good. And the reality is, early on, ultrasound studies often reflect the practices of ultrasound experts. As you do later studies, they reflect ultrasound being adopted by all users, right? So there's folks like, ultrasound faculty who are, they do a lot of ultrasound. That's what they're good at. And so their test characteristics may differ than other folks' test characteristics who interests are mainly in airways or in resuscitation or in vent management or in musculoskeletal stuff. So you kind of always need to look at those things. But in this case, the data suggests that basically ultrasound makes you more successful at aspirating a peritonsillar abscess if it's there. It also still persistently means you don't talk to ENT as much, which I think probably is good for them. You know, they don't need to be woken up for every peritonsillar abscess, I don't think. I think that's something that's well within our wheelhouse. I think it's something that we should be able to handle without involving them most of the time. Sometimes we need to, but most of the time we don't. And then the utilization rate of CT was still pretty low. And as you can see, again, some people are still going to say, hey, I'm still going to get that CT. And I don't think that's wrong. I think the wrong answer is to always get the CT. But sometimes things don't make sense. You're not totally sure, and that's not an unreasonable situation to get the CT. Interestingly enough, and I thought this was really important, if you used ultrasound for your diagnosis of peritonsillar abscess, the patient was less likely to bounce back, which probably reflects some diagnostic ambiguity in the landmark approach. Was kind of my thought looking at the literature, but ultrasound makes you better in my opinion. All right, so let's talk a little bit about the ultrasound. So whenever you're looking at this is an intraoral ultrasound. You're going to spray some hurricane spray in the back of the patient's mouth. Be careful not to overspray or else you'll give them hemoglobinemia, and that's kind of poor form because then you have to call Dr. Metters and talk to her and say, oh God, what do I do? But you're going to get an image like this. You're going to basically just put the transducer right against the tonsil. This long thing right here is actually the carotid artery, so you get a direct view of that. And then that right there is the tonsil. You're genuinely seeing it, okay? So you can kind of provide a little bit of pressure, and you can actually see that that carotid kind of pulsating with that pressure, which is a nice way of kind of looking at this. Okay, you can even throw color on it, and as you can see up here at the top of the screen, there's actually a little bit of an abscess. We'll show you a couple of pictures here. So when you're looking right here, see, yeah. So this is the abscess right here, right in the middle of that tonsil. Right, it looks like hypoechoic, looks like any other abscess. Often it'll have a little rim around it. This is another example where again you see just tonsil, but it's got this dark kind of mixed echogenicity fluid around it. It's a little bit more liquidy. Okay, this is kind of scanning through a tonsil, and this one again looks much more like an abscess that you'd see like in the skin or anything else, but this is just within the tonsil. And the nice thing here is you can actually see almost like it's a little bit hyperechoic, a little bright around some of the edges, which is kind of like it's getting a little bit of a rind to it, and that kind of helps kind of show it. You can measure it so you can get an idea of the volume of it and how much you're going to get, right? If it was like, hey, I'm measuring out this tiny little abscess, it's a milliliter, that's going to be hard for me to hit. There's not much to get out of that. Versus if you're like, hey, this thing is 3 centimeters by 2 centimeters and it's got a ton of liquid in it, you're like, okay, well that should be pretty easy to hit, and there's something probably worth going after. On top of that, you can actually measure the distance to the carotid. I really like this because for those of you guys that do needle aspirations, one of the things you can do is you can measure and give yourself a safety factor. You can measure to the carotid, measure to the posterior wall of the abscess, and you can give yourself a little bit of a shield so you can make sure you're not going too deep. You don't want to get an ABG out of doing a peritonsillar abscess drainage. That's poor form. So you can also do this. This is kind of sonocompression, and what you can see is that kind of movement back and forth of the abscess. So if you're like, is this abscess? Is this phlegmon? Is it just a little bit I'm not sure if this is abscess. You can just press on it. And you can see this stuff right in here, just kind of moving around. So you guys can do that with cutaneous abscesses, but you can do that with peritonsillar abscesses as well, and that can let you know that there's something in there that's kind of a semi-fluid. That you should be able to drain. Here's another example of the same thing. It's right here, and you can just see kind of right at the top of the screen, just a little bit of kind of movement as they're kind of compressing on that tonsil. The great thing about ultrasound is you can actually use it for guidance. This is actually somebody putting a needle in right here. You saw it just briefly, and aspirating under ultrasound guidance. This is a little better image, and you can see the cavity kind of going away. So you can do this in real time. They have to have a big enough mouth to be able to fit the needle and the ultrasound transducer in, but this is something that's doable. There's a nice kind of element to be able to say, hey, I did this under ultrasound guidance. Yes, sir, Dr. Payne.
So if you're going for dynamic guidance, let's say you're right-handed and it's a right-sided abscess on the patient.
Uh-huh.
Are you going to switch hands with your needle and your probe, or are you going to cross your hands? What's the best way to do that?
I'd hold the probe with my non-dominant hand if I was trying to aspirate under direct guidance, would be my answer. Dr. Lewis, do you have any disagreement with that? Cool.
Seems like I feel like this would be like, you'd have to have faith about the patient.
Yeah, it can be hard. It can be hard to do it under direct guidance. I think that's fair, but it is something that, like I said, it's doable. Now I know what you're thinking. You're like, hey, I don't often have access to the endocavitary probes. It's something that we haven't completely rolled out to all of our faculty and residents and all. Though I think it's something we should be pushing for, especially for this application. I think it's a very doable thing. But you can actually use a transcutaneous transducer. So you can actually use the curvilinear or the phased array or the linear transducer to do the same thing, and it's called the telescopic approach. You basically just put the transducer under the angle of the mandible, and you can get a pretty good picture. And there's been a couple of studies that actually looked at intraoral versus transcutaneous approach, and it's interesting because they have different strengths and different weaknesses. So the sensitivity is a little bit lower, it's around 80%, but the specificity is actually a lot higher, which is kind of interesting, and I think some of that is you get a pretty decent view, and when you see it, man, it's a slam dunk. So here's a couple of examples. Okay, so right here you can see carotid back in here kind of pulsating along with vein. This is your tonsil right here, and you see that little tonsillar abscess right in the middle. Okay, and again, color right over the carotid, just kind of showing you where that is. You can still measure it. It's a little harder to measure to the surface of the tonsil because obviously there's an air artifact and it's in the far field, but you can still measure it and get yourself an idea of a size. It's a nice option. For those of you guys who are working on shift, and it might avoid you, waiting in line for a CT. The question is, and I know some of you guys are gonna be like, well, the specificity is not so good on the endocavitary, and the sensitivity is less good on the transcutaneous. I don't want to miss this, which begs the question of, is surgical management really the right therapy? And I think the jury's still out, but there's a couple of studies that have been done that have looked at this. Okay, and they said, should we be doing surgical management? Does it matter? Does that change things for the patient? And it turns out that treatment failure in abscesses less than 2 centimeters is about 5%, no matter if you do surgical management or medical management alone. And greater than 2 centimeters, the treatment failure increases, but there's no real difference in the treatment failure between medical and surgical management, at least in one study, which is kind of interesting. And then there was no difference in surgical versus medical treatment in terms of bounce back or anything like that, other than the patients who didn't have surgical therapy were more likely to go back to work sooner and had less narcotic usage, which is pretty good. So I think there might be some element of that. Now I'll say that most still recommend IND, and at this stage in my career, I'm still doing INDs if I see an abscess. However, if I think it's a phlegmon, if I think it's really small, I have a low threshold to treat them medically. And so I think that paradigm may be changing. Again, there's relatively little data on this topic, but I think it's something worth knowing that if you see a big Goomba, there's a likelihood they're going to fail even if you do aspirate, or even if you do drain them, I guess I should say. But there's a chance that they may come back. But if it's small, the difference is probably relatively minimal. I'd still probably try and drain it, but just realize that, that drainage may not be as critical as we think. And really, if that drainage is less critical, then I'm kind of okay with a test with a little bit more borderline test characteristics. You know what I mean? Instead of like a slam dunk 100%. Yes, sir.
Was this specific to PTAs or this is abscesses in general?
This is peritonsillar abscesses. These were 2 studies on peritonsillar abscesses. All right, so basically, everything should be ultrasounded by all people at all times. Questions?